Professor Ramesh is a professor, head of the Department of ENT and Head and Neck Surgery at St. John's National Academy of Health Sciences, Bangalore. He started his medical education in 1990 at JIPMAR, Pondicherry, and completed his post-graduation from All India Institute of Medical Science, New Delhi. Following this, he worked with the tribal of Nilgiris to establish a community-based early detection of rehabilitation program of deaf children, and he continues to work with them till date on voluntary basis. He has invented and patented the following products, processes, and healthcare paradigm in the domain of early detection and rehabilitation of hearing impairment. Number one, calibrated noisemakers of hearing screening in medically underserved areas, which has been recommended by the Ministry of Health and Family Welfare, Government of India. Mobile soundproof minibus that has been utilized in 6 regions of India to conduct a survey and provide ear care services at subsidized cost by ICMR task force. Integrated indigenously designed and manufactured hearing aid system to assist and monitor auditory speech and language training for deaf children by their parents anywhere in the world, and that is by BIRAC funded. Parallelism to empower communities established early detection and rehabilitation of deaf children using local resources with minimal assistance from healthcare personnel. In the domain of noise reduction technology, he did the noise cancellation technology in neonatal intensive care units. He is the chairman of subcommittee that developed standard treatment workflow for pediatric hearing impairment, Department of Health Research, Ministry of Health, Family Welfare, Government of India. In the domain of knowledge of creation techniques, developed an innovative method to train healthcare personnel in creating new knowledge to solve healthcare challenges. That is the Research Genie app. Presently, in the process of creating new knowledge in the area of inclusive education of deaf children, ICMR funded artificial intelligence to predict loss to follow up after neonatal hearing screening, that also ICMR funded project. He has many publications in both international and national journals. So I welcome Professor Ramesh in this webinar. Sir, we are grateful to you to be the expert of this today's classroom. I welcome
My
you.
honor, sir.
Welcome,
My
sir, to the
honor,
board.
sir. Thank you. Yeah, and pleased
Thank you,
to meet
Dr.
all of you.
Shubhankar. Yeah, thank you, sir.
Thank you.
Actually, now next, our speaker presentation introduction. Our secretary usually does it, and he is somehow he is not here. He is busy. So, Joint Secretary Dr. Mohan is there. Are you there? Hemanto Mohan? Dr. Hemanto? I can see him. Dr. Hemanto?
Yes, yes.
Can you introduce Dr. Priyanka Chetia, speaker?
Just wait. Just wait. Okay, a little bit.
Any problem, Dr. Mohan?
Yeah, little bit of problem is there. Yeah, sure.
Right. Can I help you?
Yes, yes. Can you just little bit of help?
Can I do the, yeah? Hello, Dr. Hemanto?
Yes, 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 yes.
Can I will introduce Dr. Priyanka?
Yes, yes, that will be helpful. That will be.
Okay.
Okay,
Dr.
go ahead.
Priyanka Chetia, she is from Sibsagar, Assam. So she has pursued MBBS from Assam Medical College, MS in otolaryngology and head and neck surgery from Silchar Medical College. And currently she is doing senior residency at the Department of Otolaryngology and Head and Neck Surgery, Dhubri Medical College and Hospital, Dhubri, Assam. Have been awarded the prestigious Swami Vivekananda Award for the first best scientific paper at 35th Annual Conference of NEBAOI 2024 at Sibsagar, Assam. Won Best Paper Award at IMA Medimit 2025 at Silchar, Assam. Have paper publication in the international journals of pharmacy research and technology. Have attended and presented papers in various regional and national conferences. So I welcome Dr. Priyanka Chetia. Welcome to the forum. Thank you very much. And may I
Thank
request
you for
our pardon?
thank you,
Now,
Pooja
may
Vaidya.
I
You have just described nicely. Thank you. Thank you.
thank you, thank you. May I request Hiranya Bora Madam, who is Chairman Scientific Committee, to introduce our moderators.
Okay, I welcome all of you to this session. First of all, as moderator, I welcome Dr. Ranjan Kumar Nath. He is presently working as Associate Professor, Department of ENT, Fakhruddin Ali Ahmed Medical College, Barpeta. He has 15 years of professional experience after his post-graduation. He passed his master degree in ENT and head and neck surgery from Guwahati Medical College, Assam. He successfully organized more than 10 specialized hands-on workshops over the past decade. About research and publications, he is author of a few national and international publications in peer-reviewed journals. I welcome Dr. Ranjan Kumar Nath as moderator of today's session. Our another moderator is Dr. Priyam Sharma. She completed her MBBS from Guwahati Medical College in 2009. She completed her post-graduation in otolaryngology from Guwahati Medical College under Srimanto Shankardev University of Health Science in the year 2015. She served as resident in Fakhruddin Ali Ahmed Medical College, Barpeta from July 2015 to March 2016. She completed 6 months mentorship program in Nightingale Hospital in 2017. She went for observership training in laryngology under Dr. Joykumar Menon at Tiruvananthapuram. She was part of organizing team as treasurer at Phonocon 2024 Guwahati. She is currently ENT consultant at Nightingale Hospital, Guwahati, and visiting consultant at Apollo Hospital and Palon Rewak Rehabilitation Center. Her subject of interest are evaluation and management of swallowing disorder and phonosurgery. I welcome Dr. Priyam Sharma as today's moderator. Thank you.
Thank you, Hiranya Madam. I welcome Dr. Ranjan and Priyam to the forum.
Thank
So may I request Dr. Priyanka Chetia to start her presentation? Dr. Priyanka, please. You can start. Make it full screen and first slide.
Audible, ma'am?
Yeah, audible.
Yes.
But slide, it is not first slide. Make it a full screen.
Okay.
Do it full screen.
Is it okay now, ma'am?
No, no, not full screen. You did it a few minutes back, no? Yes, full screen. Do it full screen. Yeah, click it. Click there.
Is it okay now, ma'am?
Yeah,
Mm.
you can start.
Okay, shall I start, ma'am?
Yes, you started.
Okay. Good evening, respected President of NEBAOI, Dr. Shubhamay Chakravarti, sir, our esteemed expert, Professor Dr. Ramesh A. sir, respected Chairman of the Scientific Committee, Dr. Hiranmay Bora, sir, and respected Secretary, Dr. Anjan Jyoti Bhuya, sir, our
Hiranmay
respected
Bora,
moderators, Dr.
Priyanka.
Priyam Sharma, ma'am, and Dr. Ranjan Nath, sir, my respected teachers, seniors, and dear colleagues and juniors. Thank you for giving me the opportunity to present here today. I'm Dr. Priyanka Chetia, currently working as a senior resident in DMCH Assam. So today my topic of presentation is laryngopharyngeal reflux and the understanding of current concept. So I'll be giving the brief introduction, then I'll move forward to epidemiology. Then I'll discuss about the difference between LPR and GERD. Then I'll talk about the anatomy, physiology, and pathology. Then finally, I'll go to clinical presentation, diagnosis, management, and recent advances. So let's start with the first slide, that is the definition of laryngopharyngeal reflux or LPR. What is LPR? LPR is the retrograde movement of gastric contents into the larynx or pharynx, which results in inflammation of the upper aerodigestive tract. It may occur with or without typical symptoms of gastroesophageal reflux, and it is also termed as extraesophageal reflux disease or reflux laryngitis or laryngopharyngeal reflux disease. Many patients with LPR do not complain of heartburn, making the diagnosis challenging. A significant proportion of patients with LPR present without classic GERD symptoms, and many first seek care from the ENT specialist rather than a gastroenterologist. So coming to the epidemiology, the prevalence varies from 10 to 50%. It is very wide because there is no universally accepted diagnostic standard for LPR. Approximately 10% of patients attending ENT clinics may have symptoms suggestive of LPR. It can occur at any age, most commonly diagnosed in the 4th to 6th decade, and there is no consistent sex predilection. So associated conditions are chronic cough, chronic rhinosinusitis, asthma, and in professional voice users like teachers, singers, etc. So coming to the next slide, these are the risk factors. In lifestyle, we have smoking, obesity, tight clothing, lying down soon after meals, and sedentary lifestyle. In dietary risk factors, we have caffeine, alcohol, chocolate, fatty and spicy foods, carbonated drinks, late night meals. And in medical factors, we have hiatus hernia, delayed gastric emptying, esophageal dysmotility, pregnancy, and connective tissue disorders. Most patients have multiple contributing factors, and lifestyle modification remains the cornerstone of initial management. So coming to the next slide, though LPR is most commonly found in adult patients, but it is also common in children. So who are prone to LPR? Infants and young children, premature infants, children with neurological disorders like cerebral palsy, children with congenital airway anomalies, obese children, and adolescents. And they present with chronic cough, hoarseness, recurrent croup, stridor, feeding difficulties, recurrent otitis media, apnea, or cyanotic episodes. So now let's discuss the difference between LPR and GERD, as we often confuse both of these conditions. So LPR mostly occurs in the upright position, but GERD mostly occurs in the supine position. Esophagitis and heartburn are mostly present in GERD, but it is very uncommon in LPR. So the sphincter primarily involving LPR is upper esophageal sphincter, but in GERD, the lower esophageal sphincter is involved. And the LPR patient typically presents with hoarseness of voice, throat clearing, cough, and globus, but the GERD patient generally presents with heartburn, regurgitation, and chest pain. So now discuss about the anatomy of the pharynx and larynx. So in this slide, we can see the anatomy of the pharynx and larynx. So the anatomy is the gastric content runs from through the esophagus and reaches the laryngopharynx. The hypopharynx and larynx are the primary site
জায়গা দিতা না তার মধ্যে চালো দিয়ে দিলা তো চালো দিয়া না দিলে ভাবছিলাম
in
মুখে দেওয়া খায়
and
আর মালা
yeah.
মালা পাপড়ি দিয়ে
The
রঞ্জলি দিয়ে
posterior
আমার
larynx is the most common barrier against reflux reaching the airway. The laryngeal mucosa is highly sensitive to acid and pepsin because it lacks the protective mechanism that is present in the esophagus. So now let's talk about the anti-reflux barrier. So the most important anti-reflux barrier in LPR is the lower esophageal sphincter. It is a high physiological high pressure zone at the gastroesophageal junction, which prevents the retrograde movement of the gastric contents. Then the anti-reflux barrier, second anti-reflux barrier is the esophagus, which propels the refluxant back to the stomach by primary and secondary peristalsis. Then coming to the upper esophageal sphincter, it is formed mainly by the cricopharyngeus muscle, and it acts as the final barrier preventing the reflux from reaching the pharynx and larynx. Diaphragmatic crura also provide additional external support to the lower esophageal sphincter. So now coming to the next slide. Next slide is about the physiology of the anti-reflux barrier. So these are the things that I have explained in the previous slide, that it maintains a high resting pressure that is 10 to 30 millimeter of mercury, and it prevents the retrograde flow of gastric contents into the esophagus. The upper esophageal sphincter is mainly formed by the cricopharyngeus muscle, and it maintains a high resting pressure of 40 to 100 millimeter of mercury. Then there are some other physiology of anti-reflux barrier also. These are esophageal peristalsis. The primary and secondary peristalsis clear refluxate and reduces the mucosal exposure to acid and pepsin. Impaired clearance increases the reflux injury. Then comes the sodium bicarbonate. It neutralizes the acid that comes from the stomach content. It also helps wash the gastric content into the stomach. Then coming to the mucosal resistance. Esophageal mucosa has mucus, bicarbonate, and tight junctions. These are the protective mechanism of the esophagus, which is lacking in the laryngeal mucosa. Hence, even brief reflux can cause injury to the laryngeal mucosa. Coming to the gravity and posture, upright posture promotes reflux clearance, and supine position delays the clearance. So, post-meal recumbency increases the reflux episodes. Coming to the pathophysiology, there are two types of theory. The first theory is direct theory, that is the reflux theory. The mechanism is the gastric contents comes in direct contact with the laryngopharyngeal mucosa, where the pepsin is the principal injurious component in LPR. Pepsin remains stable at neutral pH and is reactivated after subsequent acid exposure. Repeated exposure leads to mucosal inflammation, edema, and epithelial injury. The clinical significance is laryngeal mucosa is more susceptible to injury than esophageal mucosa. LPR may occur even in patients with normal esophageal acid exposure. Symptoms may persist despite minimal acid reflux due to the damaging effect of the pepsin. So, from this slide, we get to know that the pepsin is the principal injurious component in the LPR. So now coming to the next theory. The next theory is also called the reflex theory. The previous one was reflux theory and the second one is reflex theory. According to this theory, reflux does not need to reach the larynx. Acid exposure in the distal esophagus stimulates vagal afferent receptors, triggering an esophago-laryngeal reflex. This reflex produces symptoms such as chronic cough, frequent throat clearing, occasionally laryngospasm, even without direct mucosal injury. Repeated coughing and throat clearing can themselves traumatize the laryngeal mucosa, creating a vicious cycle of persistent symptoms. This explains the symptoms in patients with minimal or no laryngeal mucosal injury. Direct mucosal damage is not essential for symptom generation and often coexist with the direct reflux theory in the same patient. So let's talk about the role of pepsin. There is a hypothesis called the two-hit hypothesis. So pepsin is now regarded as a central mediator linking both the direct and indirect pathways. So in the first hit, during a reflux episode, pepsin is taken up into the laryngeal epithelial cells by receptor-mediated endocytosis, even when the gastric content is weakly acidic or near neutral. In dormant phase, it is internalized. Internalized pepsin remains stored within the cell in an inactive state without necessarily causing immediate visible damage. A subsequent reflux event, even a mildly acidic one, lowers the intracellular pH enough to reactivate the stored pepsin, which ultimately causes the reactivation of pepsin and which causes ultimately lead to inflammation and mucosal damage. So now that we have understood about the anatomy, physiology, and the pathophysiology, now let's talk about the laryngeal and laryngeal symptoms. So the most common symptom is hoarseness. Then we can also have frequent throat clearing, chronic cough, globus pharyngeus, dysphonia, or voice fatigue in these patients. So voice fatigue especially is found in the professional voice users like singers and teachers or clergy in those patients. And there is reduced vocal range. There is voice breaks or intermittent voice instability and increased need for voice rest. There is associated symptoms like burning sensation or throat discomfort and excessive throat mucus production. So now we will observe the laryngoscopic finding in a patient with laryngopharyngeal reflux. So what are the findings that we can see here? So we can see the posterior commissure hypertrophy, diffuse laryngeal erythema and edema, thick endolaryngeal mucus, pseudosulcus vocalis, ventricular obliteration, and vocal process granuloma or contact ulcer. So I have included a short video of 70-degree laryngoscopic view of LPR that I have done in my ward. So the patient was having a lot of gag reflex. I tried to mute the video, but it didn't happen. So now let's talk about the reflux finding scope. So Beletsky et al. In 2001 developed a finding score in which there are 8 videolaryngoscopic findings, each scored and summed, and a total score, a score of more than 7 out of 26 supports the diagnosis of LPR. The 8 videolaryngoscopic findings are subglottic edema, ventricular obliteration, erythema or hyperemia, vocal fold edema, diffuse laryngeal edema, posterior commissure hypertrophy, granuloma or granulation tissue, and thick endolaryngeal mucus. And these are the score range. So another index is there, which is called the reflux symptom index. It is also developed by Belevsky et al. It is a patient-reported questionnaire used to assess the symptoms suggestive of LPR. So the things that are assessed are hoarseness or voice problem, frequent throat clearing, excess throat mucus or postnasal drip, difficulty in swallowing, cough after eating or lying down, breathing difficulty or choking episode, troublesome or chronic cough, global sensation, heartburn, chest pain, indigestion, and acid regurgitation. Each item is scored from 0 to 5 and maximum score is 45, and RSI more than 70 is considered to be LPR. So now I will move to the diagnostic evaluation, and it should happen in a stepwise manner. In step 1, we will do the clinical assessment, where we will take the detailed history and symptom. We will do the detailed history and symptom evaluation and reflux symptom index for symptom assessment. And in step 2, we will do the laryngoscopic examination. We will do the flexible laryngoscopy or 70-degree laryngoscopy, whichever is available, to identify characteristic findings. Reflux finding score helps to quantify the laryngeal changes. Then in step 3, we will go to the objective testing. Multi-channel impedance pH monitoring, which is the gold standard when diagnosis is uncertain. We also have dual probe pH monitoring in selected cases, and we can also do salivary pepsin assay. In step 4, we will go for the empirical treatment. The first thing that we will advise is lifestyle modification. Then we will go for proton pump inhibitor trial in selected patients. Then we will reassess the patients, and we will do the laryngoscopy again before starting the prolonged medications. So now let's talk about the 24-hour multi-channel intraluminal impedance pH monitoring. The principle of this investigation is that it measures both the acid and non-acid reflux episodes, and it also detects the frequency, direction, and composition of reflux. It correlates reflux even with the patient's symptoms over the 24 hours. The advantage is that it detects acid, weak acid, and non-acid reflux. It is more sensitive than conventional pH monitoring, and it is useful in patients with persistent symptoms despite PPI therapy. So now let's move to the other investigations, that is the salivary pepsin assay, which is also called PEP test. It is a rapid, non-invasive lateral flow immunoassay performed on expectorant saliva, and it detects the pepsin as a direct biomarker of a pharyngeal reflux exposure. It is office-based, it is inexpensive, and it is very well tolerated by the patients. So now let's go to the oropharyngeal pH monitoring, which is also known as RESTEC. Dual sensor probe placed in the oropharynx detect the aerosolized and liquid reflux events. It is an ambulatory testing without the discomfort of a standard transnasal esophageal catheter, and it is useful adjunct when standard esophageal pH testing is inconclusive. Now let's move to the empirical PPI trial. It is considered in patients with typical symptoms suggestive of LPR after clinical evaluation. And the standard regimen is PPI twice daily, 30 to 60 minutes before meals for 8 to 12 weeks. Should always be combined with dietary and lifestyle modification. And we should reassess the symptoms using RSI and laryngoscopic findings after treatment. The limitations are that the response of PPI therapy is variable. Many patients have non-acid reflux or non-reflux that causes of symptoms. routine prolonged PPI therapy without objective evidence is not recommended. So the differential diagnosis of LPR are allergic rhinitis, which mimics throat clearing and mucus sensation. There is muscle tension dysphonia. We have chronic rhinosinusitis. Then we have irritant laryngitis, eosinophilic esophagitis. We have Jenker's diverticulum, primary laryngeal neoplasm, and Sjogren's syndrome or xerostomia. Let's come to the lifestyle modification. So in dietary changes, we should always advise the patient to limit caffeine, alcohol, and chocolate, and to avoid fatty and spicy and fried food, to reduce carbonated beverages, and to have smaller and more frequent meals. In behavioral changes, they should avoid meals within 3 hours of bedtime, and they should elevate the head of the bed 6 to 8 inches. They should avoid tight-fitting clothing to prevent increasing intra-abdominal pressure, and they should remain upright after eating. In general health advices, we should advise them to reduce weight and to stop smoking and regular moderate exercises and stress management. So coming to the medical therapy, the first line is PPI, which is most widely prescribed medical therapy for LPR, typically dosed twice daily before morning and evening meals. Standard trial duration of 3 to 6 months before reassessment. The examples of PPIs are omeprazole, pantoprazole, esomeprazole, rabeprazole, and lansoprazole. Then we have H2 receptor antagonist. It reduces the nocturnal acid secretions, complementing PPI action. But tachyphylaxis can develop with prolonged continuous use. So we should be limited with the use of H2 receptor antagonists. The examples are ranitidine, famotidine, and nizatidine. So we have prokinetic therapy also, which is used in patients with delayed gastric emptying and functional dyspepsia and significant regurgitation. The examples of prokinetic drugs are etopride, domperidone, and metoclopramide. So let's talk about the surgical options that are available. So we should remember that surgery is not the mainstay of treatment. It should be done in selected patients. So we have surgical options of laparoscopic nascent fundoplication, which is the 360-degree wrap of fundus around the lower esophageal sphincter, which is the standard procedure that we do. We also have toupee, which is the partial fundoplication, in which we wrap 270 degree. The fundus is wrapped 270 degree around the lower esophageal sphincter. Then we have a new procedure that is called magnetic sphincter augmentation, and it is done in selected patients where available, because it is not available everywhere. So I have included one video of nascent fundoplication. So we can see that the fundus is wrapped around the lower esophageal sphincter, and it is acting like a belt, and it is providing support to the lower esophageal sphincter. So it will ultimately prevent the reflux of the gastric contents to the esophagus and larynx and pharynx. So now let's talk about the complications of GERD before moving on to the LPR. So the esophageal complications are reflux esophagitis, esophageal ulcer, peptic stricture, Barrett's esophagus, esophageal adenocarcinoma in late stages, upper GI bleeding, and esophageal perforation, which is a very rare complication. So some extraesophageal complications are chronic cough, preservation, pneumonia, dental enamel, chronic laryngitis, halitosis. So the laryngeal complications are laryngitis, vocal persistent burst sensation, chronic throat clearing, excess throat mucus, and the airway complications are laryngospasm, chronic cough, subglottic stenosis, and in some cases aspiration. So we also have some ear, nose, and sinus associations with the LPR. The diseases that are associated are chronic rhinosinusitis, persistent postnasal symptoms, OME, eustachian tube dysfunction. The oral complications are dental enamel erosion, burning mouth syndrome, and halitosis. In pediatric age group, we can have feeding difficulties, recurrent croup, chronic stridor, recurrent laryngitis, apnea episodes, and aspiration pneumonia. So these are some controversies and recent advances that I will discuss in the subsequent slides. So let's move on to today's next slide. So in recent advances in diagnosis of LPR, we have gold standard test, which is 24-hour Hemi pH monitoring, which remains the most objective diagnostic test. It detects both acid and non-acid reflux reaching the hypopharynx. We have some newer diagnostic tools that are salivary pepsin, MNBI, that is mean nocturnal baseline impedance, and we have Restec oropharyngeal pH monitoring. So the recent advances in LPR is that in medical therapy, PPI shows limited benefit in isolated LPR, and alginates have better evidence, which forms a raft barrier and inhibit pepsin. The emerging therapies are pepsin inhibitors, which mainly targets the pepsin, which is the key laryngeal irritant. We have some HIV protease inhibitor named as fosamprenavir. And we also have upper esophageal sphincter augmentation devices, which are under investigation. We have surgical options for refractory cases that we already discussed in the previous slides, that Nissen fundoplication, toupee fundoplication, and links. This picture shows the Nissen fundoplication, toupee, and links. So this is my last slide, and I have the key messages from the whole PPT. So the diagnosis of LPR is evolving, and no single gold standard test exists. Hemi pH monitoring is the most objective tool. Salivary pepsin and MNBI are promising adjuncts. Manual review of Hemi pH data is essential. In the treatment portion, treatment is shifting. PPI show limited benefit in isolated LPR. Alginates provide better symptom control. We have some novel therapies that are pepsin inhibitors, HIV protease inhibitors, upper esophageal sphincter devices that are the emerging therapies. In surgery, we have Nissen, toupee, and links. Some associated factors that matters in laryngopharyngeal reflux are: it is higher prevalence with OSA, allergy, and somatic anxiety. It is most commonly found in older age groups, especially women. And we should manage the contributing conditions, which will ultimately lead to better outcomes. So that's all for today. These are my references. Thank you, everyone, for your patience.
Thank you, Dr.
Thank you.
Priyanka. Thank you
Thank
very
you,
much
Dr.
for your beautiful presentation. So, may I request our expert,
Ma'am.
sir, Dr. Ramesh, to enlighten us? Ramesh, sir?
Yeah. Yes, madam. Thank you. I think Priyanka is, can you hear me, ma'am?
Yes.
Hello?
Priyanka?
Yes, sir. Yes, sir.
Can you hear me, ma'am? Good. Dr. Priyanka, I must say, well presented and, what to say, beautifully designed slides, which comprehensively and in a focused way you presented the whole topic. I think she has more or less presented the whole gamut of information that is there on laryngopharyngeal reflex. I already add some of my practical experiences. Other people who are there on the panel also can comment. Most of the times, what I've seen is there's some undue stressor. Patient is otherwise perfectly okay. There is some undue stressor in their life which will precipitate this condition, and that's a very important. Many times I tell my residents, they just superficially, take just the history of laryngopharyngeal reflex and just leave it at that, and probably give them immediately some proton pump inhibitors. And what happens is usually the patient gets symptomatic relief till they take those proton pump inhibitors, and again they come back with the same LPR. The main what precipitated the whole thing has to be taken into consideration, and some little bit social history is very, very critical. There will be some adjustment issues or some kind of enormous family or some professional disturbances that will happen, and that will cause this whole laryngopharyngeal reflex. So as a in via media or temporary measure, we can look at all these medical things, but in the long run, the person has to we have to listen out to their issues that they are dealing with, and probably put them in touch with a counselor or a psychologist who can bring in some long lasting, like you said, stress management. That's very important one. And secondly, things like yoga, which will increase the tone of the lower esophageal sphincter, has been shown to have uh, very long lasting effects. It's again very simple in their workplace, and something maybe 10 to 15 minutes they can practice some of these and get long lasting results. So that would be my some observations from my practice. Thank you.
Thank you, sir. Our moderators,
Thank
Dr.
you so much,
Ranjan and
sir.
Dr. Priyam. Dr.
Yes,
Ranjan and
ma'am.
Dr. Priyam, can you give your inputs, please, and you take the questions as well?
Yes, ma'am. Am I audible, ma'am?
Yes, yes.
Okay. So
Priyanka,
first
can
of all,
you stop sharing your slide?
Yes, ma'am.
yeah. So Priyanka, terrific presentation. I must congratulate you. It was very comprehensive, and you almost covered all the topics. There's nothing much to discuss. We'll have a beautiful, I think, description later on. I'll just add one thing. I think you missed the name of the person who coined the term laryngopharyngeal reflux. It's Dr. Jamie Kaufman. Before that, it was a very vague term. It was called reflux laryngitis or non-specific laryngitis. But Dr. Jamie came up with a nomenclature for this disease that we are dealing with. It's laryngopharyngeal reflux. It was very comprehensive. I would have loved a bit of description on the laryngoscopic findings, because we, in this part of India, we are still lacking behind in terms of investigative protocols or diagnostic investigation. So we are relying very heavily on what we see in our clinical practice or in laryngoscopic findings. But apart from that, very nice. Over to you, Dr. Ranjan.
Yes, it is indeed a very comprehensive presentation. So there are few questions put by our esteemed delegates. First question is, am I audible?
Yes, yes.
Yes, sir.
Yes, you
So,
are.
Yeah. First question is put by Dr. S.B. Fukan sir. Is there is any automatic neural therapy in LPR?
Autonomic
Autonomic neural therapy in LPR.
theory. Autonomic neural theory.
That is his first question. Actually, he put 3 to 4 questions altogether. Doc- Dr. Priyanka, can you go
The
through?
autonomic neural theory, not autonomic neural therapy. Theory.
Neural theory.
Autonomic neural theory.
Yes.
Yes, in LPR.
So, sir, in cases of gastric reflux comes to the lower esophageal sphincter, there is stimulation of the vagal receptors, which will ultimately of the esophagus and upper esophageal sphincter, leading to the symptoms of laryngopharyngeal reflux, that is LPR.
So,
Uh,
I think it
Dr.
is
Fukan, sir.
Sir Ramesh sir. Ramesh sir can tell. Ramesh sir, can you?
Hello, what is it?
No, madam, I can't hear you well.
Sir,
Dr.
Fukan sir is asking, sir, there is autonomic theory is there, autonomic neural theory.
Not that I'm aware of, ma'am, which is there in the standard literature. There could be studies I haven't explored.
Fukan sir, please
Priyanka,
elaborate. Fukan sir.
probably Priyanka is the most well placed. Have you done a comprehensive literature review? Have you found anywhere, Priyanka, where they are looking
I
at
found
this?
something. I'm not sure, but I found that sympathetic has sympathetic takes upper hand than parasympathetic. That is one is there, I think. Parasympathetic goes down and sympathetic takes up. Fukan sir can elaborate. Fukan sir. Fukan sir.
If I may interrupt.
Yeah, Priyam, please explain.
Yeah. So what we have seen in literature, it's basically vagus nerve mediated. It's a reflux. So what happens in this case, it's not direct mucosal injury. The vagus nerve stimulation is by the presence of acid in distal esophagus, and it causes the patient to have anytime dry cough. So after persistent coughing, dry coughing, the patient then develops mucosal lesions, which are mimicking laryngopharyngeal reflux. While in the mucosal theory, there is actual mucosal damage, which causes cough. In the vagal mediated theory, the cough comes first, and then it causes the mucosal damage that we see in the laryngoscopic findings. So these are the two things that I have come to see in the literature. Apart from that, I'm not very aware.
I have come with Priyam. You have already
Yes,
told
sir.
there is a reflex, vagal stimulation, the chronic cough, irritating cough. Some patient you
Irritating cough.
see
So cough comes first.
so much cough, you cannot recognize. Everything is normal, but then you can detect. But problem is that LPR is a mature reality. Without doing the probing test and other things, you cannot confirm it finally. Thank you.
Yes.
Yeah. The second question is put by Dr. Anjana Sharma, madam. Her question is there is any hypertrophic gastric mucosa in post-cricoid area in LPR?
Yes.
Is there is any laryngoscopic finding of hypertrophic gastric mucosa in post-cricoid area? That is her question.
Priyam?
I am not aware because usually in LPR, we do not go for directly upper GI endoscopy, but it may be there because it's a very new subject on the horizon. So maybe we are not aware.
Ramesh sir? Anjana, can you explain? Dr. Anjana?
Yes, actually, I have gone through some papers It is said that it's in many cases of LPR, the upper esophageal and lower esophageal sphincters are functioning normally, but there is an evidence of ectopic gastric mucosa either in the postcrical region or in the upper esophagus. So that is creating problem. I have gone through some literature. So that is like it looks like salmon patch and all in endoscopy. That's what but I have never seen it, but I found in literature.
Okay.
Thank you, Dr. Anjana.
Next question is again by Dr. S.V. Fukan sir. He is asking about the role of alginic acid, RAF technology, and is there any role of SSRI? Dr. Priyam.
Sir, I think, yeah, Priyanka, I
Yes,
think
sir.
you mean.
Priyanka, yes.
Am I audible, ma'am?
Yeah. Yeah, you
So
can continue.
alginates plays a very important role, and in recent studies, it has been shown that the alginates are better drugs than the PPIs because it forms a gel-like substance by mixing with the gastric contents, and it forms a physiological barrier which prevents the mucosal injury of esophagus and the laryngopharynx. And the SSRI, sir asked about the SSRI also. I think LPR is also associated with anxiety, particularly somatic anxiety. So I think the SSRIs have role in that. The
Okay. Next question is from
Hello?
Nascent
Yeah,
Group.
Priyam, can you add something?
Yeah, I'll just add exactly, but there are no modulators in these cases because in patients who are not responding to PPI or alginate therapy, some patients have shown response to GABA B agonist drugs like baclofen. So apart from doing their neuromodulator thing, this GABA B agonist also have a role in reducing the amount of reflux. But obviously, these drugs are a bit complicated. This is going to be some problem in patients who are not tolerating neuromodulators well. But new therapies on the horizon, and we should be keeping eye open for any new literature on this. GABA B agonists.
Yes, Piram, you are very right. That is particularly for the hiccup. This baclofen is used in
Yes.
hiccup mainly. And also it can be used in this.
Yes, right.
Yes, very right. Thank you for.
Yes.
Is there any role of tryptomar, amitriptyline? Dr. Priyanka?
Not directly, obviously, but yeah, new studies are still coming up.
Sometimes it is used in chronic cough, amitriptyline.
Yes.
So next question is from Nascent Group. They are asking role of upper GI endoscopy and Helicobacter pylori. That means if Helicobacter pylori is a controversial thing, some studies says that it is a common cell organism, and others believe that it is a pathogenic. So, is there any comment on that, Dr. Priyanka?
sir, I'm not aware of this.
Priyam, you can answer. Priyam?
See, ma'am, I think she covered in the first initial slides. LPR and GRD are not mutually inclusive or exclusive. So a person who is having GRD is not necessarily having LPR, and the person who is having LPR is also not necessarily GRD. But there are going to be group of patients who have both. So in those patients, since we do not know which patient is falling in which category, if you even have a hint of doubt, it's always advisable to go for upper GI endoscopy. If there are findings that we get in upper GI endoscopy which are suggestive of some form of gastritis or GERD symptoms, then we can obviously go for H. pylori testing. But again, it depends on the clinician's discretion.
Madam, I have something to add here.
Gastroenterologists, they do.
Yes, sir.
Gastroenterologists usually do the upper GI endoscopy and do the biopsy from the stomach content. Then they do, if the H. pylori is positive, they go for the kit. There is a combination of the
Yes.
clarithromycin, erythromycin, amoxicillin, or your PPI. They go for it. But I think, as Ranjana said, it is a controversy. But if you cannot tell, you should not tell like this because gastroenterologists will not find good. I think. Thank you.
Dr.
Madam,
Ramesh wanted to say something, ma'am.
Yeah, madam, in this, see, for my younger colleagues, we have to be very careful about this pharmacology. See what happens, patients come with LPR, then they're given one medicine, then after that they come back with something else, then they're given another medicine, then they come back with something else, and it goes on and on and on. Then some scopy is done, then some investigations are done. And sitting in St. John's, many of them finally, I've seen patients coming all the way from Bengal because they have gone through this whole thing. But what has not been looked at all is there would be some underlying stressor. That history and that has not been taken care at all. And then the multiple physicians are giving a lot of medications. Of course, medications are temporary relief, but the most important thing, again, I want to stress is this fundamental thing that has precipitated their laryngopharyngeal reflex should be taken care of. So, for the younger colleagues, don't get stuck with multiple medicines and investigations, especially in LPR.
That is true, sir.
Yes, I totally agree with sir. Absolutely.
Yes.
Next question is again from Nascent. Is there any role of PCABs? Any
I think
role
it's
of
Dr. Biswajit Gogoi.
Yeah.
Yeah. So I'm not sure what is the full form of PCAB. Sir, can you please elaborate?
Yes, sir. Yes, sir. Actually, a new drug named vonoprazan is arising, which has a faster action, and it does not require the acid to activate to work. So it is a new drug.
Okay. Okay, so there is another question. His or her name is not there, but 1+. Should alginate be given before or after food? Should alginate be given before
Should be
or
given
after
before food
food?
only, sir.
As far as I know, Priyanka, alginate should definitely be given after food. And that is also, I think, half an hour after food, because it's supposed to prevent reflux. It's not supposed to prevent acid production. Am I right, sir? Fukan sir and Ramesh sir?
Yeah, I also heard like that. After food, half an hour after.
I know, that's true. And that the pharmacological basis, what madam has said, why it should be given after food.
Ranjan, this is Keshav.
Yes.
Okay, I would like to add a few things. Like Dr. Ramesh has already said, that you should look for the potential stressors. See, most of the reflux patients do come with they have a lot of anxiety in them. So once you identify that, because how the patient explains to you, how the patient is speaking to you, and with whom they have come, all those things, can give a clear picture of idea that what kind of stress, or whether there is a stress associated with the patient or not. In I would say in most of the patients, up to 90% patients, you will definitely get some kind of a stress associated with the laryngopharyngeal reflex. So what I do, as you said that regarding that amitriptyline and tryptomer, so that in those identified patients, I usually co-prescribe that, so that it gives a good results, better results, along with the PPI and along with the alginates and all.
Okay. So I have a question. Chronic cough, global sensation, and dysphonia often have multiple etiologies. What clinical feature help you differentiate LPR from allergy, muscle tension dysphonia, and functional laryngeal disorder? Do you understand, Dr. Priyanka?
Can you repeat the question again?
See, chronic cough, most of the patients present with chronic cough, as you have mentioned earlier, global sensation and dysphonia. So, what clinical feature help you to differentiate LPR from other allergic disease, muscle tension dysphonia, and functional laryngeal disorder?
Sir, in cases of allergic rhinitis, the patient will also have excessive rhinorrhea, and sometimes they have itching in the ear also, and they will have post-nasal drip, like something stuck to the throat. And in muscle tension dysphonia, the patient will complain of
Mainly hoarseness.
vocal fatigue. If we go for the laryngoscopy, then in muscle tension dysphonia, we might find some other findings like sir, I can't remember the findings.
It's okay.
Dr. Priyam, can you elaborate?
I'm not very sure. Actually, we
can-
should be going to the questions. We still have, I think, 4 or 5 questions left in the chat
Yeah,
box.
yes.
Yes.
Fukan sir has asked a question about L-cathephrine and carbonic anhydrase. I think it's related to pathophysiology. Priyanka? Hello?
Sorry, ma'am, I'm not
Yeah,
aware.
because it's not very commonly discussed. I think carbonic anhydrase enzyme is interrupted by this presence of pepsin, and it causes some kind of mucosal changes. I totally forgot exactly how, but it's involved in this reflux theory, not in the reflex theory.
They break the mucosal barrier, I think.
Yes. Dr. Parul Mathur is asking how long the patient can have PPI. What is the duration of PPI we can give? Priyanka, the question is to you.
Yes, ma'am.
If not,
Earlier, we preferred to give the PPIs for 6 months, but nowadays it is like 8 to 12 weeks. That is 2 months to 3 months maximum.
Okay.
Is there any other question?
Yes,
Dr. H. Mohan is asking, I think, kindly explain LPR with H. pylori. I think it has been covered before with the upper J question.
Excuse me.
Sudeep.
Yes, yes.
Priyanka, can you relate that?
Yes,
Because
sir?
H. pylori. Hello. Yes. Because
yes, we are
H.
here.
pylori.
Yes, sir. I'm here, sir.
Yeah. H. pylori is predominantly seen, particularly during upper GI endoscopy. They do a root test. Usually, those who are doing endoscopy, upper GI, they commonly do the H. pylori test. And it is observed commonly those patients having H. pylori positive. Most of the patients having H. pylori positive have more number of having LPR problems. So In that case, is there any definitive study that is helping to identify the problem, whether the H. pylori is more in cases of problem along with the LPR? LPR is more, that means LPR, those patients having LPR, particularly with positive H. pylori, then how they correlate?
Sir, association of H. pylori with LPR.
Yes, yes. Because I have discussed with my gastroenterology friend. And I discussed with them. So they said most of the time they do this root test, means H. pylori test. And most of the time, the H. pylori is positive in patient having gastritis or gastric patient or reflux patient. And they have more amount of, observed that they have more amount of LPR in them.
Dr. Priyam, I think she has explained. Can you, Priyam, tell?
Yes, it's literature based. We have not done any studies per se, but in literature, GERD and LPR are not always concomitant. But I think this is a very new subject, recently coined term in the last 20 years or so. So I think more studies are coming up, and I think we'll have a definitive relation in the years to come, but still not very directly established that all GERD and H. pylori cases will also have LPR, and all LPR will also have GERD.
Excuse me, Priyanka, can you, because
Yes,
this
sir.
term is also coming, silent reflux.
Yes, sir. It is used for LPR, sir. Sir,
Yes.
can you hear me, sir?
Yes. Kindly,
So it is a
kindly
term
let us know
that is
something
used
about
for
silent reflux.
laryngopharyngeal reflux, sir. Because in
Yeah.
cases of LPR, even the mild acid can cause injury to the laryngeal mucosa. And because the key ingredient to the mucosal injury is pepsin, which is already present in the laryngeal mucosa by the endocytosis of the laryngeal cells, then even a mild acid will reactivate the pepsin, and it ultimately leads to protein degradation, intracellular protein degradation, and laryngeal mucosal injuries, sir.
Okay, explain. Thank you.
Okay, next question is from Dr. Sudeep Kumar Nath. He is asking, is there is any relation between lingual tonsil hypertrophy and LPR? Dr. Priyanka. Lingual tonsil hypertrophy and LPR. Is there is any association?
Yeah.
Question by Dr. Sudeep Kumar Nath.
Sir, I don't know about the direct association, but in LPR also we have the granular pharyngitis. That is the enlargement of the lymphatic
In the posterior pharyngeal wall.
tissue in the posterior pharyngeal wall. But here I think same manner the lingual tonsils will also get enlarged.
Priyam, please. Dr. Priyam, can you?
Yes. No, ma'am, I have not got any direct relation with lingual tonsils.
Madam.
Dr. Ranjan, a comment in the chat box from Dr. Ruby.
Madam, Dr. Ramesh
She's
here.
reiterating. Yes.
Oh, yes, sir.
Yeah, madam, I just want to comment on one thing. See, in medical science, association can be anything, can be associated with anything. It is a very statistical game. As long as the moment you reach a particular number, you can associate anything. I keep, again during my classes, I tell you can associate the number of cars passing by my hospital with the number of deliveries happening in the labor room, as long as it reaches a particular number. And see, and these games are mainly used by pharmaceuticals to promote something. They can twist the treatment pathways in any way they want. So in this whole game, no, we should not be missing the woods for trees, taking one small thing here, one small thing there, and then treating something here, treating something there, and then finally the patient gets confused, and the overall picture is not looked at. So very critical that the overall picture is looked at, and as one of my colleagues pointed out, with the anxiety, stress, the background, all those things are very important. Otherwise, they should, these pharmaceutical interventions are just temporary, just to get over the acute phase probably, but not for long term. And again, my opinion, I have not done any major studies, but again, what I've seen in patients, these are not for long term use at all. That's my opinion. Thank you.
You're absolutely right, sir. One of my patients, she has written one line here. She's Dr. Ruby Varghese. She's an alumni of IAMC, my classmate, and she suffered from GRD and probably LPR. The only thing that helped is yoga and diaphragmatic breathing, just like Dr. Ramesh said in the beginning. So she has noted that one. Thank you, Ruby, for sharing. Priyam, can you finish up the question?
Yeah.
Yes,
Yes, ma'am. I think it's already finished, ma'am.
Yeah. So I think we have come to the end, and
As the subject is very controversial, whether it is always said that LPR and GRD, LPR is whether there is myth or reality. Without doing the probe test and the pH monitoring, the final diagnosis cannot be given. Even the gastroenterologist cannot tell that Helicobacter pylori positive case is having more LPR. Never, actually, because treatment is completely different. They give clarithromycin, amoxicillin, PPI, this thing. Therefore, this thing is very controversial. As Dr. Ramesh has told that how many cars are going to the hospital and how much delivery is like the relationship. Therefore, you cannot tell. But a very good discussion. Thank you.
Now, sir, can I say something?
Yes, sir.
Yeah, yes, sir.
Actually, if you go through the recent advance by Moffat et al. In 2015, there one line they have written, it was the transient lower esophageal sphincter relaxation. Now, generally, what happened when you will find that the GERD, so there is a complete relaxation of the transient lower esophageal sphincter relaxation by 10 to 45 seconds, which should not be, because the lower esophageal sphincter is much more having this rather than the gastric sphincter. So what happened during this time, this mechanism, it fails to this relaxation, transient relaxation of the lower esophageal sphincter. That is one of the main mechanism of the GRD. Now, what happened when, as Dr. Anjana has told in one point, that whether is there any evidence of any gastric mucosa can be seen, it can be seen when there is an ERD of this patient. We are concerning much more about the ERD. In pediatric cases, we are getting some pediatric cases, unresolved your otitis media with effusion. And it has been established that in pediatric cases, you have to exclude the ERD because chronic rhinosinusitis, adenoiditis, and unresolved otitis media with effusion is the main problem at present in USA. And that is why, again, they have seen in different studies that it is one of another cause is your duodenogastроesophagitis. Why the gastroenterologists, they always used to perform the endoscopy and is to take the biopsy, because nowadays there is another thing is coming, and this is the duodenogastроesophagitis. That is also another thing, and that is why they always used to take the biopsy from the antrum. You will find they will never forget to take the biopsy from the antrum, pyloric antrum. right? They used to take the specific biopsy from those side, and it has been seen not in all cases, but in cases H. pylori becomes positive. So what they have started that Bilitech 2000, which is not available in our country at present. I think, I don't know whether it is. Dr. Ramesh, are you using Bilitech 2000? Bilitech 2000.
No, sir.
I don't think so. It is available. So in USA, I was going through some of this year. So what they are doing. Bilitech 2000. They used to do that test whether is there any bile component is also there. So it is nowadays they are giving much more importance in that duodenal gastroesophagitis like this, right? So
Thank you, Dr.
your
Shubhaman.
transient lower esophageal sphincter relaxation is the mechanism. There is the. So definitely there must be some sorts of your neural involvement in that area also. So,
Thank you very much, Dr. Shubhaman. I think we have come to the end of the classroom. So now the vote of thanks on behalf of the Scientific Committee of NEBAOI. It is my privilege to propose the vote of thanks. We express our deepest gratitude to Dr. Ramesh for his enlightening expert comments and for sharing his vast clinical experience on the evolving concept of laryngopharyngeal reflux disorder. Your guidance has enriched our understanding and will certainly influence our clinical practice. Our sincere appreciation goes to Dr. Priyanka Chetia for her excellent presentation delivered with clarity and science depth. We also thank our moderator, Dr. Priyam Sharma and Dr. Ranjan Nath, for conducting the session so effectively and making the discussion lively and interactive. Thank you very much, Dr. Priyam and Dr. Ranjan. I would also like to express our heartfelt thanks to our President, Dr. Shubhamoy Chakraborty, Dr. Anjan and Dr. Hemanta Mohan, and all the office bearers and members of NEBAOI for the constant encouragement and support in promoting academic excellence. Finally, I extend my sincere gratitude to every participant whose enthusiastic presence and valuable interaction made today's classroom truly meaningful. As Henry Ford rightly said, anyone who stops learning is old, whether at 20 or 80. Anyone who keeps learning stays young. Let us continue to learn, share, and grow together. Thank you all. Have a wonderful evening. Thank you, everyone. See you in the next classroom.
Thank you.
Thank you, everyone.
Thank you very much.